So this was an important talk and an important topic for pain physicians everywhere. We've made a lot of advances in the field of neuromodulation, generally speaking, and specifically spinal cord stimulation over the last 50 or 55 years. Part of that has taken from a framework of we're stimulating the spinal cord in a very simple manner, and we're now applying more, I'll say, comprehensive principles of understanding complex science paradigms around this. That begins with understanding how it works to a much greater degree than what was given to us by Melzack and Wall, two great scientists from the 60s, advancing that through novel waveforms, activation of the cord, and through clinical outcomes. And understanding the spectrum of scientific aspects of clinical care is really going to be very important in optimizing patients' outcomes for years to come. Really an interesting set of parameters is that Dr. Vallejo challenged conventional thought, challenged how we thought about neuromodulation, that is simply stimulating large fibers to turn off small fibers, what was the gate control theory. And he recognized that in the spinal cord, there are a lot of glial cells or inflammatory cells, and that we have the ability to activate and inhibit these glial cells with electrical parameters. Now, why is that important? Probably because there's more than just A-beta activation in spinal cord stimulation and its effect on pain control. There are a lot of factors, and what he has done is he's picked out one aspect of this, and he has started to tease this apart to provide information from the animal lab that could potentially be translated to the human clinical experience for neuromodulation. So it is applying scientific principles from ideas to animals to human trials, and eventually big data will lead us to this, it really does work better for patients, or this is a fad. I personally believe this is one big step forward towards improving our understanding, which will improve our ability to care for patients. There are probably a few areas of medicine, in pain medicine today, that are really particularly exciting. Use of ultrasound is allowing us to find nerves that we couldn't find before. Regenerative medicine, broadly speaking, stem cells and PRP and those types of approaches are going to open a new window into what we can do to help patients without surgery. And then the last, as you ask, is the field of neuromodulation. This is such an exciting time for physicians to be involved in this area. You know, for many years, we would consider spinal cord stimulation as a very simplistic approach where we would activate large fibers to turn off the small fibers. But over the last 10 years, there has been a virtual blossoming of information, of new approaches, new ideas, new therapies that might be more effective in controlling our patients' pains. With that, we need to do the science to really show that this is an effective therapy, that it's more effective than what came before, and thus by doing so, we can optimize our patient care. Another area that's kind of interesting within the peripheral nerve stimulation area is the use of very specific electrodes, things that we were doing back in the 60s, but we've really optimized the technology to a much greater degree to place electrodes in the periphery on specific nerves to turn off pain control, both for the short term and potentially for the long term. And these are really exciting opportunities, particularly in the area of the opioid epidemic that many people have heard about and many people think about. We now have some therapies that are alternatives to opioids that are very relatively simple to apply and to perform, that can optimize the pain control without the necessary risks when somebody goes on systemic medications. So one of the great advantages that I see going forward, particularly in the peripheral nerve stimulation area, as well as with spinal cord stimulation area, is that the devices are becoming much more miniaturized, much more simple, which, you know, in some ways sounds bad, but it's actually really good. This opens up neuromodulation to a much broader spectrum of physicians who can implant these devices if they have those skills of ultrasound and the skills of a good diagnostician. Implanting the devices are actually quite a bit easier today. And the technology that's been developed allows us to do this with minimal pulse generators, or even in some cases not having a pulse generator at all. So some of the new technologies that are being developed with peripheral nerve stimulation have a new concept, new ideas about how neuromodulation works. The idea is that by actually stimulating some of these nerves with specific patterns of nerves, we can apply this for up to 60 days, and at the end of the 60 days, the pain's gone, remains gone for a long period of time. This isn't the paradigm that we thought about early on when we were thinking about neuromodulation. We originally thought that you had to be stimulating the nerve to have the pain be gone. But what we learned is there is some reconditioning or reversal of that central sensitivity that can occur with some of the patients. And this really does a couple of things. Well, of course, it provides great pain control for some patients, but also, importantly, it pushes neuromodulation up sooner in the algorithm. Would you rather have something that is safe, reversible, that can be done very early on in the treatment strategy, before drugs and before surgery? I think we're going to be rethinking a lot of these issues with the new technology that's become available to us.